Okay, hello everybody. I'm Andrea Moser. I'm your facilitator for today's ECHO. Welcome. Right now we have 45 sites online, so welcome to everybody. Today we're going to have David Kahn from Baycrest and University of Toronto talk to us around the topic of delirium in the context of the COVID pandemic. So with that, I think I'm going to mute myself and pass the microphone over to David, who's going to talk to us about delirium.
Thanks, Andrea and team. Thanks, everybody. Appreciate you joining this morning. We're going to be talking about delirium today and potential relationship with the pandemic. So there we go. Okay, just to show that I don't have any conflicts of interest to declare, no financial support, and I'll do my best to be evidence-based, although interestingly enough, there's a lack of evidence around this issue at the moment. So the learning objectives, so by the end of today, I'm hoping you'll be able to list key precipitating factors for delirium, be able to select an appropriate screening tool or tools, be able to describe some strategies to prevent delirium, be aware of the association between COVID-19 and delirium, and to outline some management approaches in the current circumstances. This image by Salvador Dali, I think, sort of expresses that sense of distortion and lack of ability to follow time that people who are delirious experience. This was a recent editorial by Shane O'Hanlon from Dublin and Sharon Inouye, who's the sort of guru of delirium from Harvard. An editorial saying that delirium is a missing piece in the COVID-19 pandemic puzzle and that it's been under-recognized. And the editorial comments that guidance from the US Centers for Disease Control and from Public Health England completely ignore the issue of delirium in talking about COVID-19. So the actual criteria for delirium are as follows. There needs to be a disturbance in attention and awareness. It develops over a short period and represents a change from baseline, tends to fluctuate during the course of a day. There's at least one other cognitive disturbance. And then it's not explained by some other condition, and there's evidence from history, physical exam, or laboratory findings that this is a disturbance due to a medical condition, substance intoxication or withdrawal, exposure to toxin, or multiple etiologies. And these are kind of the main things that we see. So the disturbance of cognition, impairment of consciousness, and particularly attention, psychomotor disturbance, circadian rhythm changes, and emotional dysregulation. There are two major categories of delirium: hypoactive, where people are very lethargic, somnolent, sluggish, versus the more classic hyperactive delirium, where people become very agitated, potentially hallucinating, and there are challenging behaviors. Or you can get a combination of the two, where the person may be hypoactive for part of the day and then hyperactive, often at night. This comes from an amazing paper by Jose Maldonado, which really, if you're really interested in delirium, this is one amazing paper. It's very detailed. It really explains as much as we know about the underlying mechanisms that cause delirium. And he actually describes the hypoactive, mixed, and hyperactive, but also says at the very extreme ends, you can get catatonic excitement or catatonic retardation. So the overlap between dementia, depression, and delirium is important. This comes from the RNAO and nicely outlines the difference. Of course, many people with dementia get superimposed delirium, and so you can have the two going together, and you can actually get the three happening together. So this is confusing, but there are differences in onset, course, duration, and levels of alertness and attention in particular that differentiate delirium from dementia. So, delirium has an acute onset. It has a fluctuating and short course, relatively short compared to dementia. These changes in attention are really critical. These are further differentiating factors, but I think it's the first group that are most significant. So how often does delirium occur in older individuals? Well, a lot depends on the setting. So it's not that common in the community. It's very common in hospitals, particularly on general medical or surgical units. very frequently occurs post-operatively, particularly with large operations like hip fracture. It's not well studied in long-term care homes, although I'll give you some data in a minute. It's very frequent in palliative care and in intensive care units. This was a recent Ontario study, actually, looking at over 1,500 residents in 12 long-term care homes. This was a McMaster-Schlegel study. They found that over the 32 months admission, on average, of the residents, there was an incidence of 40%. So it's some time over the course of their admission, 40% had an episode of delirium. And not surprisingly, there's an association with dementia, pain, and antipsychotics. A recent Spanish study over 1 year found an 18% incidence, so it's pretty common. The predisposing factors, so increasing age, cognitive changes, of course, dementia, impaired function and disability, any kind of sensory impairment, dehydration and malnutrition, drugs, alcohol misuse and withdrawal, coexisting conditions, all of these increase your risk. And the actual precipitating factors, the things that are more likely to set off a delirium, again, drugs, particularly psychotropics, narcotics, anticholinergics, again, withdrawal, and then infections, surgery, metabolic physiological changes, organ failure, hypoxia, of course, very relevant to COVID-19, and then all of the environmental interventions that can complicate things, such as being in an intensive care unit, use of restraints, and so on, as well as sleep deprivation, stress, and inadequate pain control, all contributing. So what do we actually understand about the underlying pathophysiology of delirium? It's complicated. That paper by Maldonado that I mentioned describes some of the underlying mechanisms that can include neuronal aging, something called neuroinflammation, so excessive inflammation that can take place in the central nervous system. And this seems to be a particular issue with COVID-19. Oxidative stress, changes in the neuroendocrine systems and circadian dysregulation, as well as all the neurotransmitter changes and network disconnectivity that can take place. And this slide shows the many different changes in neurotransmitters and hormones that can take place caused by different types of illness. You can see there's a lot of change. The one that really stands out, of course, that we know clearly about is anticholinergic activities. So if you have enough anticholinergic activity, anyone could become delirious. And the classic findings are being hot as a hare, dry as a bone, blind as a bat, because your vision's affected, red as a beet, and mad as a hatter. That's considered to be the classic effects, side effects of anticholinergic drugs. Many drugs do have anticholinergic effects. So delirium is often under-recognized by both nurses and physicians, perhaps for various reasons: the fluctuating course, the overlap with dementia, lack of formal cognitive assessment in many settings, not knowing that this is actually a dramatic change, because you sometimes usually have to speak to family members or other caregivers to find that out, and just a general underappreciation about the importance of delirium. Oh, as well as ageism, aren't all older people actually confused? So this is the first polling question. So which delirium screening tool is most often used in your setting? Is it the confusion assessment method, the CAM, delirium symptom interview, nursing delirium screening scale, or another tool? Or maybe you don't use screening tools that often, just do a general assessment.
And we see people are already starting to type in CAM.
So Canadian guidelines from the Canadian Coalition for Seniors Mental Health recommend the CAM, particularly for acute medical and surgical wards and in the ER. The delirium symptom interview is actually recommended in complex cases, and there's a special instrument that's used for alcohol withdrawal. And the CAM, this is the CAM, so it's simple. So you require both acute onset and fluctuating course, inattention, and then either disorganized thinking or an altered level of consciousness. So, if you're CAM positive, it means you might the patient might have delirium, and therefore we need to do a comprehensive assessment, of course, at that point, taking a full history, particularly recent change in cognition and function, past medical and psychiatric history, any physical symptoms, including pain, bowel and bladder changes, mood, behavior, sleep changes, as we said, medication, anything new, anything over the counter as well, substance use and withdrawal. And then it's always important to do a relevant physical exam, mental stat examination, and then appropriate investigations, including various lab tests that are listed here. I won't go into them in detail, but obviously we need to figure out what is the cause of the delirium. If it's possible to do an MMSE or a MOCA, that's great. Often it's very difficult because the person may not pay attention to you to begin with, and for a whole variety of reasons may be very ill. But the one thing that's worth asking about are tests of attention. So, and there's a whole variety of those in this test, including the letters, reading out the list of letters, which requires good attention, or getting someone to give you the months of the year and then forward and then in reverse. That's another very useful test. Usually people with delirium will have a lot of trouble with attentional tests. One of the reasons that delirium is considered to be a medical emergency and the person should be investigated is that the outcomes from delirium are not very good. So, and of course that's because individuals with delirium are very ill. But in hospitals, there's increased length of stay. There's increased mortality rates. So with older adults, the mortality rate may be as high as a third. And then in the longer term, for hospitalized patients, there's an increased risk of institutionalization. And although we generally think of delirium as being reversible, a significant percentage do go on to have some persistent cognitive impairment. And there's a lot of debate about the reasons for that. But it could be because of changes that occur during delirium, such as neuroinflammation, that actually cause further brain damage. So delirium is generally reversible, but not always. And it may also be the first sign of an underlying dementia. So what do we know about delirium in COVID-19? So I'm going to ask you to just, if you could on the poll, just to name one factor that might increase the risk for delirium in people who are severely ill with COVID-19. Appreciate all of these very relevant answers to this question. So multifactorial, obviously. Thank you. That's great. So, so there have been a number of recent publications looking at neurological manifestations of patients with COVID-19. This came as an early paper, came from Wuhan itself, and they found that 36% of patients had neurologic symptoms of various kinds, more common in patients with severe infections. And so there was a small number of individuals who had small strokes, and you've heard perhaps of the increased risk of stroke and thrombotic events with COVID-19. But there was also a significant number that had impaired consciousness, which is probably equivalent to delirium, although it's complex. And they weren't looking for delirium here, by the way. This paper from France looked also at neurological features, but what you'll find there is that 65% had positive findings on the CAM ICU, and 69% were agitated. So it does sound like a very significant portion of these individuals with more severe infection had what we would consider delirium. A great paper by Kotvis from Poland and colleagues from Vanderbilt in the US described the challenges of looking after people with COVID-19 in ICUs. And they talked about some of the risk factors for delirium, including direct CNS invasion by the virus, CNS inflammatory mediators, the secondary effects of other organ system failure, sedatives, prolonged ventilation, immobilization, and then the actual isolation and complex environmental factors that make things worse. This comes from their paper, and it's very interesting. It's by intensive care specialists. And they talk about a whole variety of factors that increase the risk of delirium. And I was surprised by this paper because they took a really humanistic, whole person approach to this. Yes, they talked about evolving neurocognitive dysfunction, but they also talked about restricted visitation, the limitations of non-pharmacological interventions. They're harder to provide. And then, general uncertainty about the pandemic, disruptions to religious, spiritual services, as well as professional workload and burnout among staff, as all contributing, interestingly. And I was so impressed. One of the things, I'm just going to quote from that paper, what they said is, what is needed now is not only high quality ICU care concentrated on providing adequate respiratory support, but an identification of the source and degree of mental and spiritual suffering of patients as well as their families to provide the most ethical and person-centered care during this humanitarian crisis. And they wrote further on that we must view the fulfillment of mental and spiritual needs as a medical intervention. So last poll question, how often can delirium be prevented in hospitals, in hospitalized patients? So it's interesting, I'm impressed. So people think that delirium can be prevented very often, at least half of the time. Okay, thank you. So, so this comes from the HELP program and also the RGP, who produced this lovely image of ways in which we can prevent delirium. So one is what they call stimulating the mind. That really is doing things to keep the mind active, and as well as orientation, of course, repeated orientation to help the person stay oriented, but moving, so dealing with immobility, sleeping well, doing everything we can, but not giving drugs, seeing and hearing, making sure people have their hearing aids and glasses, staying hydrated, and ensuring people have good, healthy food. So this all comes from the HELP program that was developed by Sharon Inouye in the States and then spread all over North America and I think to other countries. Her landmark study 20 years ago compared this kind of intervention with usual care. And what they found was that the prevalence of delirium in the usual care group was 15%, and in the intervention group, just under 10%. So that would suggest that about a third of all cases were preventable using this program. If you go to the HELP program, right now they've got information on how to use that program during COVID-19 and some of the challenges, and we can provide the link to that. They also have a kit for helping people that staff can use to help people to implement this program. Here are some other resources from the Canadian Coalition for Seniors Mental Health, including a separate guideline document on delirium at the end of life. The RGP from Toronto also has some wonderful resources, including this one and others. So in terms of management, non-pharmacological, of course, is treating all potentially correctable factors. We want to get the person well again, but at the same time, preventing the person from harming themselves. Some suggested environmental strategies, avoiding sensory deprivation or overload, adequate lighting, use of clocks and calendars, avoiding room changes, use of familiar objects, and avoiding putting delirious patients in the same room together. Always like that one. This is from the RGP site, is very helpful. It's communication tips for clinicians caring for older adults experiencing delirium during this pandemic. Very useful. I like this one though. They're talking about remembering to smile even if you're wearing a mask, because although they can't see your face, they can hear it in your voice. But some very good advice in this particular document. And this is a great booklet from Scotland that's terrific for both patients and families explaining delirium. It's available online. When it comes to medications, most important to remember that psychotropics should only be used or should be reserved for those in significant distress due to agitation or psychotic symptoms in order to carry out essential investigations or treatment, or to prevent the person from endangering themselves or others. We don't treat hypoactive delirium with medications. Antipsychotics are the treatment of choice, with the exception of alcohol or benzodiazepine withdrawal. And if we have to use something, we would either use very low dose haloperidol or an atypical antipsychotic such as risperidone. Very low doses of Haldol, and there are some cardiac complications that we have to be careful about with prolonged QTC. So where feasible, if you're going to use Haldol, a cardiogram is recommended. And benzodiazepines really are reserved for older persons with delirium caused by withdrawal from alcohol or sedatives. That's the guideline. They're still sometimes used in certain circumstances, but we do try to avoid them. There was hope that cholinesterase inhibitors like donepezil, Aricept might be helpful to prevent or treat delirium, but that hasn't panned out in studies. So to conclude then, so delirium really represents acute brain failure, and there are many precipitating factors to consider. The use of screening tools is really useful, and I can see that the CAM is considered the one that's most often used, but studies have repeatedly shown that if you use a screening tool, then you'll identify delirium much more often, miss it less often. Patients with severe COVID-19 illness are at high risk of developing delirium for many reasons, and this needs further study. Preventative strategies can reduce the incidence of delirium. Optimal treatment of underlying causes, of course, is critical. And management includes non-pharmacological, environmental approaches, with the use of psychotropic medications being reserved for those in severe distress or in danger of harming themselves or others. And I'll stop there.